Okay, guys, trying this again. Thank you, guys. I started to start things off a little bit earlier this evening because I am trying out some new software. And here's what I really like about this software is it's going to allow me to broadcast to YouTube at the same time I'm broadcasting to Facebook. So those of you out there who prefer YouTube, go ahead and check out my YouTube channel, Cosi Talks, and you should be seeing the same video, and you'll also be able to send me messages. So guys, those of you who are out there right now listening, if you don't mind, while we're kind of waiting for people to jump on board, if you can kind of give me shout outs in the comment section, just so I can get familiar with this particular software. We got our first person. Hey, Kristen girl, what's going on? We got Daniel on board from Facebook. So guys, if you prefer to watch from YouTube or you're just kind of curious to see what it's like, go ahead and hop over to my YouTube channel. It's also Cosi Talks, pretty easy to find. All right, let me know. Hey, Lynette, thank you. All right, good. We're seeing some people jumping on board. Okay. All right, guys, like I said, learning the ropes for this new software here. All right, guys, thank you for giving me shout outs and letting me know. Hey, Mark, thank you. So you're tuning in from Facebook. Okay, this is cool. So I figured, tonight's kind of a quiet session in the Cosi Talk studio where it's just us. So I figured this is a good time to kind of troubleshoot this new software for my live event in July. And guys, I'm so excited about this live event, and I can't wait to tell you guys more about it. Larry, oh my goodness, Larry, I haven't seen you in a long time, and I'm so glad you're here, Larry. So guys, cheers. I'm kind of changing it up just a little bit. My kids drank all of my soda, my preferred soda. So it's a Corona for me tonight, this evening. Yeah, too soon? I don't know. Cheers, folks. So yes, I am broadcasting to my Facebook page as well as YouTube. So one of the reasons I wanted to do this is because I did know that there were a lot of people that wanted to watch my show, but they're not necessarily on Facebook or Instagram. So I finally found a software that's going to allow me to branch out just a little bit. So guys, if you prefer to watch from YouTube, you can do that. We've got William Mays from Richmond watching from YouTube. Thank you, William. Thank you so much for helping me out with this. Casey is the first time you tuned in on time, Pacific Coast Time Confusion. Oh, wonderful, Casey. Well, I'm so glad that you're here live. So if you have any questions, I'll be able to hopefully answer them for you right now. We've got Jennifer in from Southern Illinois. Good to see you too. We've got Patrick on board. What's going on, Patrick? We've got David listening in from, yes, I got lots of hairs cut. We've got Tom from Wichita, Kansas. We got, let's see, David Donahue with sweet tea in hand. We got Bonnie Baird here drinking her coffee. Cheers, folks. Thank you, Lisa. I appreciate that. Yeah, it was time to kind of change it up just a little bit. Hey, John. Good to see you, man. Cheers, guys. Let's start off tonight with a cheers. All right. I am ready. So guys, I am so excited tonight to answer some questions. We've got some really interesting questions here that came in over the past couple of weeks that I've been kind of saving up for tonight, and also talking to you a little bit more about the live event in July. All right, we got Mona on board. Mona, what's going on, girl? All right, guys, I'm going to go ahead and jump on board with my questions. We're going to jump on board with the first question. Actually, it's from David Donahue. So David, I think you were on board this evening. Your question's up first. David says, first day at rehab. Oh, wait, I should probably introduce myself because I see some new names on here. Hello, I'm going a mile a minute and not really thinking about things. So sorry, guys. For those of you who are new to this show and wondering who in the world I am and what am I doing here, my name is Cosi Bayoso. I'm a physical therapist, amputee specialist here in Tampa, Florida. I've been a PT now for over 17 years, and my passion is working with the limb loss community. So I have a private practice here in Tampa that is exclusively for working with amputees, and now doing this show and expanding it a couple different places to both Facebook and to YouTube. So excited about that. Let's see who else jumped on board. We've got Timothy in from Minnesota, Lisa, Carlos from North Carolina, another Tar Heel. Welcome, Carlos. All right, comments are slow on Facebook, Daniel. Okay, so guys, hey, Benny, thank you for tuning in from YouTube. So guys, like I said, new software tonight. So if you don't mind giving me some feedback on this software, I would really appreciate it. It'll help me kind of fine tune things for later shows. So let's get back to David's question. David said the first day at rehab after his amputation, he had to transfer from the gurney to the hospital bed. And he says, I asked for a walker. and the nurse said I had to earn one. They wanted to assess what I could do. So I took 3 big hops to the bed, and a little while later, they gave me a bed alarm and refused to give me a wheelchair or walker. What happened? Okay, so this one was just one of those things, because I've had patients that this has happened to. And you know, here's what I'm going to tell you a little bit about the protocols when you go into a hospital, and specifically when you get transferred to inpatient rehab. So as we all know, fall risk goes up with amputation. Fall risk goes up even when you just become a patient in a hospital. That's just something that they've studied over decades. And one of the biggest risks in having a fall in a hospital is other injuries. And that's one of those things that hospitals try so hard to prevent. There's so many injuries that can be prevented when you prevent someone from falling. So over the past, I'd say 2 decades, hospitals have really worked hard nationwide to implement protocols to help identify people who are at high risk for falls, how to prevent falls, how to implement strategies to make sure that people don't have these injuries. Okay, so it's one of those things that they really kind of grill into you when you go to work, especially in a hospital, whether you're a nurse, a physical therapist, an occupational therapist, a resident doctor. They drill it into you. Okay, so if you have been identified as someone who is a high risk for falls, so for example, someone who recently lost their limb in an amputation surgery, someone who is above the age, depending on the hospital, someone who's above the age of 55 because they are at a higher risk for fall, someone who has sensory deficits. So if they have problems with sensation in their feet, they will be considered a higher risk for fall. Pregnant women, when they go into the hospital, they are considered a higher risk for fall. Okay, so when you are admitted into the hospital, this is part of the screening process that they do for you, so that if you are at a higher risk, basically they can try to implement some strategies to prevent you from falling, right? Okay, so we nailed that horse down. Now, with David's case, when they transfer a patient from inpatient, from the floors, to the inpatient rehab center, those nurses have to do that assessment all over again. Why? Because they don't know you yet. They can read your records and kind of, see where you were in your mobility, but they have to perform that assessment and see you with your mobility to see if you're safe enough to have a walker at your bedside by yourself. And here's another thing I want to add to it, guys. A lot of times when you go into the hospital and you're taking some of these pain medications, you may not have been a fall risk prior to hospital admission, but now that you're in the hospital and taking some of these medications, that can also affect your balance and increase your fall risk. Okay, so a lot of times these nurses, they're grilled and they have to make sure to see that they screen you for this, because if you do fall, God forbid you do fall and you have an injury, they are held responsible, not to mention that they don't want to see you get hurt. Okay, so when you see a patient who comes in fresh out of a surgery from amputation and they proceed to hop, that's actually a really dangerous movement. The ideal procedure is that the nurse can assess you right away, or that the physical therapist comes in and gives you a quick screening just to see if you're safe enough to be left with the walker by yourself, or if they need to put a sign on your door that says something along the lines of patient needs assistance with mobility, patient will need assistance with transfers, and basically putting the staff on high alert so that they can get to you as quickly as possible when you ring the bell for help. So, when I worked in the inpatient rehab hospital, often I would get called in by one of the nurses saying, hey, we got a new admission. Can you just do a quick screening and let us know if this patient's going to be safe enough to be with a walker on their own? Or sometimes the nurses would do that. Now, it can become frustrating, and I've seen this happen when you have a patient who is so eager and motivated to get moving, and the process and the procedure gets a little bit interrupted, meaning the nurse isn't able to do that assessment right away, or the physical therapist is gone for the day, so you have to wait until the next day for them to come in. So, it's not a perfect situation. It's not something that doesn't have its tangles sometimes, but this is the reasoning behind it. It's to help prevent injury from happening. So guys, has that ever happened to you before? Have you guys, let's put it up in the comments section. Yes, this is live, Carrie. You are on time. So you are catching this on time. And yes, this is live, Carrie. So guys, has this happened to any of you? I know that in working in the rehab hospitals, I would sometimes walk into my patients' rooms and they would be so frustrated because they're just like, the nurse won't let me get out of bed and I want to get out of bed. And I have to, explain to them, hey, we got to screen you to make sure that you're not going to fall and damage the surgery that you just had. So I'm curious to see how many of you had any kind of a similar experience with this. All right, and we have a lot of comments coming in, so I want to catch up with these comments. We've got Benny on board. We've got Joey from the Philippines. Oh, how are you? ¿Cómo está? Let's see. We've got Jim joining in from St. Louis with iced tea in the glass. Okay, Mark says that the comments completely stopped on Facebook. Grant, hey man, everybody, he's coming in from Utah. Susan, good to see you again. And then we've got Kay from Alaska. She says, thanks for posting the past ones on YouTube. I can catch the ones I missed. Yes, guys. So for those of you who are kind of new to watching my show, I've been expanding a little bit more with the help of my amazing tech team, Kristen. So on Wednesday nights, I'll do the live show. And then a couple of between 1 to 2 days later, a version of the show will be posted on my YouTube channel as well. So guys, if you have people that you know that might be interested in watching the show or asking me questions, and they don't necessarily like being on Facebook or Instagram, I understand. That's why I'm doing things for the YouTube channel as well. It's a little bit easier to access. So we've got Mariela from Gainesville, just back from kayaking and drinking a glass of wine. Cheers to you, Mariela. We've got Rhonda from Missouri. Oscar Loretto Jr. Oh, is in the house. That's my boy right there, Oscar from College Park Industries, my skateboarder extraordinaire. What's going on? I even got Captain in the house. All right, guys. So we're going to go ahead and go to the next question. So guys, start putting in these comments. I haven't had any comments yet. How many of you, when you went into your rehab hospital experience or inpatient acute care experience, had some problems with communicating with the staff about your mobility, that you perhaps wanted to get moving and they were not letting you move quite as much? Let's see. Jennifer says, I had to have an assessment when I came to inpatient rehab. 2 weeks later, when I was set to leave, I had to have another assessment. Yes, yes. And guys, I know it seems like, oh my gosh, I just want to get going. Will these people stop assessing me and asking me questions? But again, it really is to prevent fall risk. So, two of the big things that happen in hospitals, people falling and getting injured from falls, and nosocomial infections. So infections that are obtained while a person is in a hospital. So these are two really, really big things that hospitals try to address and create programs to help try to prevent these things from happening. So let's see. Carrie Matthews says, so William says he used a walker the first day out of surgery with help. And again, guys, that's one of the reasons that I have a job as a physical therapist, is when people have had surgery, they call us in right away to help people with their mobility, to assess the mobility, to see, okay, where are they at now with this surgery, with the medications they're on, to make sure that they're up and moving as quickly and as safely as possible, because we do want to get everyone up and moving to prevent some of those post-op complications. So Carrie asks, I have a question. Why do I get phantom pains when my leg is on? Carrie, I don't know. Okay. If you were to line up 10 different clinicians, you would get 10 different answers as to what they think causes phantom pain. And if you were to line up 10 amputees, you would also get 10 different answers as to how their phantom pain manifests itself. So Carrie, yes, in many cases, most people tell me that they feel phantom pain when their leg is off. But just the other day in my clinic, I had a gentleman who's a below the knee amputee, and we were working on something that was hard for him. It was a difficult task for him. And all of a sudden his ankle phantom pain started flaring up and his leg was on, his prosthesis was on. Basically, you have all those nerve endings at the end of your residual limb, and your brain is trying to interpret what's going on, and the signals are getting mixed up. So Carrie, this is something I've covered briefly phantom pain on the show, and I've never really done an in-depth show on management of phantom pain. And I really need to start getting on that, because there's some really great research techniques that are coming out. But Carrie, one of the first things I recommend to my patients is actually mirror box therapy. And usually when I recommend this to patients, I get the eye roll because it just seems a little too simple, I guess, for lack of a better word. For me, I like to use mirror box therapy because you're basically trying to retrain your brain. And as a bonus, you're not using narcotics. So this is a great thing to try out. It won't necessarily make the phantom pain worse. So for me, it's worth a try. So with mirror box therapy, you're basically placing a mirror in between your legs so that it looks like you have two full legs. And you look at the mirror and you look at the reflection and you don't look at your residual limb. Now, with some cases, people say that the pain goes away, and then when they take the mirror, the pain comes back. So the key with success with mirror box therapy that I have heard from other patients is consistency, to do a few minutes every day and to keep it going for a while, to be consistent with it. And then you can also kind of play around with it a little bit. Sometimes if I have a patient doing the mirror box therapy, I might have them massage the end of their residual limb while they're looking in the mirror. So it kind of gives the brain the impression that they're massaging the area that is having pain. Or I might have them rub the part of their sound intact leg. So for example, if they experience phantom pain in their missing ankle, then I'll have them rub their intact ankle while they're looking in the mirror. And everybody just reacts just a little bit different since everybody's brain is wired just a little bit differently. But no, it's not unusual to feel phantom pain while your prosthesis is on. And I will add one more thing to this and then we'll move on to the next question. So Carrie, another thing is that first year, many patients will experience the more intense phantom pain. And as you continue to wear your prosthesis and use it more in your everyday, the phantom pain does start to diminish. It may never go away. I'm not gonna sugarcoat it. It might not go away. Everyone's a little different. Some people's phantom pain diminishes into a phantom sensation. Other people, they might just have a couple of bad episodes a year. And other people, it does interfere with their daily function and they have to look to having certain medications to help with that. Okay, so hope that helped a little bit. All right, so Patrick says he had no walker, went straight to the crutches. All right, and that's gonna bring me to my next question. Let's see. Kay says, I didn't go to the rehab, but they wanted me to be proficient on the walker before I was given back my forearm crutches. I love my forearm crutches. And yes, guys, and again, this is also something that can sometimes kind of puzzle my patients where I'll walk into a patient room and they say to me, I was independent with crutches before I came into this hospital. Why do I have a walker right now? I can use my crutches. And again, guys, it's the making sure we don't get hurt. And when we go into a hospital setting, your increase for fall risk, oh, good heavens. And I've only had one sip of my Corona. Your fall risk increases. There, finally got it out. And guys, I was just going to even say, even for myself, when I had to have surgery for cancer, I was running miles before my cancer surgery. And it was funny to look at my chart and see that they had put me down as a fall risk. And I was like, yeah, okay, I guess they want to make sure I don't fall down. So let's see. Oh, thank you, Ashley. Yeah, it's one of my favorites. Thank you. John says, during my first assessment, I was told I shouldn't be in inpatient rehab after I performed everything they ask. And that's actually, John, thank you for bringing that up because that's something I really haven't covered a whole lot. Like, what is it that qualifies someone to go into inpatient rehab before they go home? Okay. So, when you had your surgery, your amputation surgery, you spent a few days on the floor becoming basically medically stable. They wanted to make sure that your blood counts are okay, that you're properly hydrated, that you're not at any risk of infection or clots or pneumonia or any other post-op complications. They want to make sure your wound is healing okay. So once you're medically stable, the hospital or the insurance company basically says, time to get out. Okay. So at that point, hopefully, you've already received a physical therapy evaluation and an occupational therapy evaluation to determine where you need to go next. So if you were able to perform what we call the ADLs, activities of daily living, getting out of bed, transferring to a chair, ideally walking to the bathroom using some sort of assistive device, whether it's a walker or a crutches or anything like that. Are you able to get yourself dressed? Are you able to perform basic hygiene? If you have steps in your home, do you know how to go up the 1 or 2 steps? So basically the PT and the OT are assessing to see if you are safe to go home. And then once you're home, you ideally go to an outpatient setting or receive home health physical therapy to continue working on your mobility. Now, if at that PT and OT assessment, they determine no, that you are not safe to go home, meaning you're not able to get yourself out of bed, or you're having really big issues with your balance, or you live by yourself, which means you need to be at an even higher level of independence to make sure you can manage safely at home, that's when they'll recommend an inpatient rehab stay. So yeah, there are some of you like John, for example, that I can imagine. I've met John, so I have a sneaking suspicion he was practically turning cartwheels before he went home, because he's a very active, very active individual. So people who are a bit more active and more progressed in their mobility, they can go straight home, versus people who have to stay a little bit longer in an inpatient rehab setting. So Carrie says, referring back to the phantom pain, that it happens when she is in it about 2 to 3 hours and have to take it off to get some relief. And Carrie, I hear that from my patients. And then the flip side to that sometimes is I hear that after they've been wearing their leg for 7 to 8 hours, they take the leg off, and that's when the phantom pain fireworks begin. Kristen, thank you. Let's see. Mark, I don't think I did get that First Step magazine. I didn't. Let's see. Grant says, the PT cleared me to get up in the hospital, and then the next day I was moved to the rehab in the same building, and the nurse there wouldn't even let me go to the bathroom, wanted me to use a bedpan. He found out just how grumpy I can get. I know, and it happens, guys. And again, it's not a perfect world. So if we have somebody who, and that would happen, where I walk into a patient room and they're telling me, I just want to go to the bathroom, I don't want to use a bedpan. So I'm like, okay, then that's our goal today, is to make sure that you can safely move out of bed, safely get yourself into and out of the bathroom, so that your nurse doesn't give you a hard time and you can use the bathroom like a normal human being and not have to use a bedpan. Hey, totally respect that. Totally respect that. Let's see. Carrie said it happened at Lowe's and husband had to find a chair to get the leg off. Yeah. Viola says, I feel phantom pain with my socket on too, as well as off. Sometimes no pain, just what is gone is still there. So it's not pain, but it's a phantom sensation. So there's 3 different things. There's phantom pain, there's residual limb pain, and then there's phantom sensation. And sometimes people get the terminology mixed up. So the phantom sensation is exactly that you have the sensation of your leg there. It doesn't necessarily have pain associated with it, but you're feeling it there. Or you have like an itchy sensation. You might have an itch where your foot used to be. Versus the phantom pain, where you're having actual pain where your leg used to be. And then the residual limb pain, where the pain is located in the limb itself, sometimes being caused either by a bone spur or a neuroma. Let's see. Oscar says, would what you're discussing be applicable to those of us born without limbs? Would a PT have discussed with my parents about what would a PT have discussed with my parents about my mobility? Absolutely, Oscar. Here's a little secret. When I was in physical therapy school, I was actually determined to be a pediatric physical therapist. So I did a lot of training for pediatrics in my early years as a physical therapist. And I spent my first year as a PT actually working in the pediatric and OBGYN units at Jackson Memorial Hospital. So yes, physical therapy is an incredibly active role in the lives of children who are born without limbs, who are born with cerebral palsy, spina bifida, and some of these other disabilities that happen with children sometimes. So education with the parents is absolutely, crucial. When it comes to children who were born without limbs, depending on what's going on with the child, we are definitely counseling the parents on how we can maximize the mobility of the child. Children are just so amazing with their resilience and their ability to adapt. And again, since the child was born without the limb, that's all they know. So from the minute they left the womb, they were already trying to adapt to their environment, the same way that a baby who was born with all limbs intact was learning to adapt to their new environment being in the world. But yes, talking to the parents about mobility, absolutely, absolutely. And because of the fact that the child's body is changing so much in those first 10 years, you're constantly having to reassess to make sure that they're not developing any bad habits, because kids they'll figure out a way. If they want to get somewhere, if they want to move, if they want to go skateboarding, they will figure out a way, which is amazing. So we just have to, as physical therapists, we make sure that we facilitate this and help the child do this in a way that won't predispose them to injuries later on in their lives. So Keitha says, an MRI shows just what the nerve endings look like after an amputation. I just had both sides shown to me what the normal side looks like, and the amputee side explains a lot. Yes, guys, and this is something where, and again, this is another show I want to do on targeted muscle reinnervation. When they do the amputation surgery, they will pull the nerve just a bit tight, clip it, and then basically release it. That's kind of a crude explanation of how they do it. And the nerve retracts back into the soft tissue. And ideally, the surgeon is kind of padding that nerve ending with tissue, soft tissue, so it's not exposed. But what happens is a lot of these nerve endings will have scar tissue forming around it, and that can sometimes cause a problem because it's compressing on the nerve, and it causes this horrific lightning bolt type pain. Nowadays, I'm starting to hear more and more about the targeted muscle reinnervation. So instead of cutting the nerve and letting it retract back into the tissue, they will take the nerve and basically plug it into a neighboring muscle. So basically it gives the nerve something to do, which is what it was always meant to do. It was always meant to innervate a muscle and send those signals. Again, one of those things that I really want to do another good show on that. Let's see. Hey, Reggie's on board. Man, I got all the College Park people in the house tonight. This is awesome. All right, guys, so let me just tackle one of the other questions that I have here. Okay, so a few weeks back, somebody, and I wanted to pick up on this question, a gentleman by the name of Daryl asked about the different kinds of microprocessor feet that are out there on the market. So in this year, we've had Blatchford, the company Blatchford in the house, and we've talked a lot about the Elan, which is their hydraulic microprocessor ankle. So because of the fact that I've had the opportunity to work with that company, that is one of the feet that I know more about because I've worked with their prosthetists and I've had a chance to get to know that particular product. That being said now, yes, all the other major companies, they do have some form or flavor of a microprocessor foot ankle. So I just kind of took from some of the bigger companies that I know of and that my patients have some of their products just to kind of give you guys an example. So for example, Oser has the Procrio foot. Blatchford, like I mentioned, has the Elan. Freedom Innovations has the Connects. And Autobach has the Meridium and Empower feet. So by no means is this an all-inclusive list, but it just to show you that, yes, different companies will have the microprocessor foot or ankle. And this is something that I really advocate for on this show is, while I will be presenting maybe perhaps on one particular foot, I encourage everyone to do their homework. If they're looking for a hydraulic ankle, if they're looking for a microprocessor controlled hydraulic ankle, if they're looking for a dynamic response foot, do your homework. Check with the different companies. More specifically, check with the reps in your area. Guys, just to get this information this evening, I texted about 3 or 4 reps from these different companies just to say, hey guys, what's your answer to the microprocessor foot? And I got an answer. So guys, these companies really want you to be able to try out their products and see what works best for you, okay? So along that line, if you are curious about the microprocessor foot, you can check back the show from earlier this year on Blatchford, where I talk about all the different kinds of feet and classifications. and also about the hydraulic foot in general. And then, yes, I do talk about the Blatchford Elan because it gives you just a basis of comparison, something that you can just a launching pad for you to compare the Elan to other companies' answers to the microprocessor foot. So I hope this answers that question. Let's see. It's a College Park party in the house right now. Hey, Harsh, glad you're here. Let's see. Susan says, such a timely conversation. I am headed to acute inpatient rehab for the short term. Yes. Thank you so much for helpful information. You're the best. Thank you, Susan. I'm so glad that you are moving on to that next part in your recovery phase. Guys, cheers. Cheers to Susan. Daniel says, I hate that no matter what, I go to the hospital after my amputation and I'm labeled as a fall risk. Even lab work at the local clinic when I'm walking at the hospital. I know, Daniel. And it's sometimes you're just walking around with a red, and for me, it's happened. And guys, I run 6 miles a day, and I've gone into the hospital and they slap a red band on my wrist, and I'm just sitting there going, are you kidding me? Really? Really? Again, it's the, after so many years of patients being injured and having these issues from falling in hospitals, they're just trying to make sure everybody's safe. So if it means you got to wear a red band every once in a while, okay, take the band off when you get out the hospital. But yes, and again, guys, sometimes we do underestimate, not in your case, Daniel, for getting blood work, but when you get admitted into a hospital and your health status is changing a bit, you can become a higher fall risk. All right. All right, guys, I'm checking with my tech team. They're telling me everything is going smoothly here. Oh, we got Jeremy in the house. What's up, Jeremy? Barbara, I'm glad you made it. All right, here, hang on. Learning to scroll here with this new stuff. Let's see, David says, one more question. If you bruise your stump badly, will it ever heal and stop hurting? A phlebotomist tray was dropped on my stump 2 days post-amputation. Oh, the bruise is still there and it's still tender to the touch a year and 4 months later. Holy smokes, David. Okay, so guys, basically when you have a bruise, it's basically because the blood vessels popped, right? And all the blood just is seeping out under the skin. And that's why it has that lovely coloring. You know, if you have a bruise that's been there for a long time, David, I would actually go back to your surgeon and ask to see if they can evacuate it. Most of the time, when it comes to bruising on residual limb, whether because the person fell or because a phlebotomist tray was dropped on the residual limb, ouch, you know, usually these bruises will resolve on their own. And sometimes you can apply a little bit of heat. For example, if you get a bruise from an IV infiltrate to break up those blood cells and get it moving. In your case, David, because it's been there for a year and 4 months, I'm going to venture and guess that blood underneath your skin has kind of clotted. And it's just kind of sitting there. So this is something that you kind of want to talk to your doctor about because this is something that they could possibly evacuate. Sometimes it's as simple, where they stick a syringe under the skin to where that blood is and they basically suck out the blood. They suck out the bruise. And that can give you a lot of relief because that bruise is pressing up on those tissues. In your case, David, it might require something a little bit more invasive because it's been there for a long time, but certainly that doesn't, no, I can't imagine, I must imagine that that's also interfering with your prosthesis and your socket comfort level to have that bruise sitting there. So yeah, I would get that checked out by the surgeon and just ask what your options are. Let's see what else we got here in the meantime. All right, here we go. John says, what ankle foot do you recommend for me, Cosi? You can answer tomorrow if you'd rather. You actually have a really nice foot, John. I believe you have College Park Odyssey. Reggie, if you're still on board, help me out. Odyssey comes in a K2 level. So I think you have the K2, John. I would be interested in seeing that as you progress with your mobility, if you might not become a candidate for a K3 level. So we can figure that one out with your prosthetist. Reggie, if you're still on board, can you answer that question for me? Odyssey comes in a K2, K3, or just a K3? Help me out here. Hey, Connie, hey, better late than never, enjoying a virtual book club. Connie, what were you reading at your book club? Oh, so Stacy says that she's getting the hydraulic foot next week. Yay me. Yeah, yay you, Stacy. Which one are you getting, Stacy? Put it down there for me. Let's see what else we got. Yes, harsh. Sometimes alternate heat and cold. When you have a bruise after it's past a certain time, they might recommend a little bit of heat to kind of break up the blood cells that are forming there. But for someone like David who's had it for so long, it's something that warrants being checked out by a surgeon before you go poking at it or doing anything there. Lee, good to have you here, man. Good to have you. Let's see, what do we got? All right, good. So I think I've got caught up on all my questions, and I've got one more question here. Ah, it's another one about feet. Okay, and it's actually quite relevant because we're right here in summertime. This question came from Connie. She says, I am a right below the knee amputee and I want to go to the beach. I have tried to get a leg to walk in sand and water. What do you suggest? So again, Connie, guys, this is a question that I was just like, I want to answer this question a little bit more in depth. Texted my good buddies, the reps from the different companies in my area, and they were so wonderful about providing input about the different feet from different companies. This is not an all-inclusive list. This is just kind of a taste to give you guys an example of what your options are. And I would encourage you now, if you're looking for a beach foot, a pool foot solution, hopefully this will kind of give you a little bit of a launching pad. So a couple of things, Connie. It all depends upon whether you're going to have a leg that is specific for the beach and the pool, or if you're looking to adapt the current leg that you have and use it. We live in Florida. We live in the water here in Florida. Even when you're a little bit further inland, you still manage to get into the water all the time. A lot of my patients will use an old socket, and if they're an above the knee amputee, they'll use an old kick around. We call it the old kick around knee, that the socket still fits. We don't want a socket that doesn't completely fit. But if, for example, they had a new socket made and the old one still can do the job, they might outfit that old socket with a water foot. So one of the examples would be from College Park. They have the Breeze foot that's available, and it's really cool because it has like a drain hole in the bottom of the foot, so all the water can drain out of there. So that's what some people do. They'll find perhaps a more lower cost foot to use with their water leg. Now, many people usually just have the one leg, so they want to use a foot that they can use for every day as well as getting into the water. So here's what I got from talking to some of the reps, my local reps. The Ottobock rep said that the Talio has a drain hole, so that's an option, and the Triton, and that they have different styles of feet from satch feet to even running feet that can accommodate and be in the water. Freedom Innovations, when I spoke to Denise, my girl Denise and Matthew, said the freestyle is meant actually for swimming, that it has the capability of plantar flexing down so that it kind of mimics the flutter kick position with a rubber cap. And also that the Maverick can be used in the water because of the fiberglass being a bit more sturdy in water, and the Cantera. Denise uses the Cantera, and she's had no problems being in the water with her own Cantera. From College Park, we have, here I'm making sure I got my names all straightened out. From College Park, you guys have heard me recommend the Sidekick Stubby Foot. I love that foot, and I love it for beach, pool, shower because it's just a great little support. It's got that nice tread on the bottom to help with anti-slip. The Breeze foot, which is what I just mentioned, also has a little drain port, and the Soleus foot. So if the Soleus, if you're an active individual, the Soleus is a foot that can accommodate to high level activity and also take you through water sports. From Blatchford, we have the Esprit, the Echelon hydraulic foot is also considered, it's labeled as being waterproof. So you guys have quite a few options when it comes to beach, pool, water, and especially now in the summertime, you should be getting out there and enjoying these water sports. So talk to your prosthetist, whether it's about outfitting an old leg and kind of just adding certain components, maybe perhaps a lower profile, maybe less expensive foot that can be used in the water. Or if you're up for getting a new foot, if it's time for you to upgrade your foot, maybe looking at to see, okay, what are the waterproof options out there? What do you guys do? I want to hear from you guys. What do you guys do for your water and beach solutions? I want to hear what you guys have to say. Oh, good. You're starting. So Stacy, you're starting with Freedom. Excellent. So you're probably going to be starting with their Connects. I think that's the name of their microprocessor foot. Let's see what else we got. Okay, so Harsh says I'm a right below the knee as well, and I got one of my old feet made as a beach foot. There you go. Okay, so Daniel says, and I'll answer this question while I'm waiting for your comments to come on in. He says, Cosi, how common is bone growth, more specifically bone spurs on the end of the residual limb? Do socket types or suspension types play a role? So Daniel, this is unfortunately a common problem that I do see in some of my patients where they will develop bone spurs. And it's exactly how the name indicates. It looks like a little spur of bone that develops usually somewhere around the end of the residual limb. Sometimes it comes off from a little bit further up, and it can have all sorts of kind of weird formations. I'll never forget one young man that came to my clinic, and he showed me the x-ray, and it was like just like a big old hook coming off of his femur, off of his thigh bone, a pretty large bone spur. So what can happen is if the bone is in the OR, some people are more predisposed to bone spurs. But what happens is sometimes with the way the bone is cut or shaved or not shaved, it might predispose the person to having a bone spur in that area. So what happens is the friction from the soft tissue will stimulate bone formation, and it'll start to form that little bone spur, which can become very painful when it starts to push up on the soft tissues. Now, there are some people who have bone spurs, and thankfully, they don't even know about it. It just happens to show up on a random x-ray. And then there are other folks that, yes, it does become a problem with the socket, and the prosthetist has to kind of jump through some hoops to make it comfortable. I have not heard about socket types or suspension types that affect the bone spur, meaning I've never heard of a socket type or suspension causing a bone spur or causing one to form or get worse. But yes, the socket and suspension do need to be adjusted to make the person comfortable. The other type of bone formation, abnormal bone formation, that's a little more rare but can still happen in traumatic amputees, it's called HO, heterotopic ossification. So in that case, there's bone formation in the muscle tissue itself. And it happens a lot in our traumatic brain injury patients. It happens in our traumatic injuries. So if you lost your limb due to a motorcycle accident, due to an electrocution accident, you would be considered a slightly higher risk for heterotopic ossification. Again, that usually forms within the first few months. I'm gonna have to look that one up again. But those are kind of like the two different types of abnormal bone formation that you might see in the amputee. All right, let's see. Daniel says, nothing like dumping the water out of your foot in front of people and seeing their reaction. Yeah, and guys, definitely when you're looking at the feet that you're looking to use in the beach or the pool, really check with the manufacturer and make sure that your prosthetist is checking with the manufacturer to see what their guidelines are, because some of these really expensive materials can get corroded with salt water or chlorine water. So you really want to make sure that you're getting a foot and you're using a foot that has been tested and approved to use in these situations. And even with the best waterproof anything, still want to rinse it off as best as possible just to minimize the wear and tear. Also sand, shells getting in there, scratching things up. So yeah, taking care of your leg. So Bobby says the ProFlex is awesome in the water. And Daniel says that he uses an old socket and the first foot to use that. Ricky uses one of his old legs. Russell takes an old foot and socket for water legs. There we go. Damon says, I just used one of the first feet I was issued when I was a new amputee. Absolutely, Russell. Let's connect at some point. Connie says, I use an old leg that I can use at the pool and at the beach. However, I cannot walk without a shoe, so I use water shoes. Daniel says, mine are making my leg bruise on the end when I walk. No bueno, Daniel. No bueno. So Johnny uses a coyote lock and a College Park soleus foot. Russell says, sometimes you can grow a bone spur just from healing quickly. For me, they said it's because I have a bone bridge that my bone spur was caused due to me being a fast healer. And again, usually by the time my patients come to me and they have a bone spur, they're a little bit ways out, so they don't know why it happened, and it becomes more about managing around it and making the person as comfortable as possible so that they can continue to use their prosthesis. So guys, I wanted to talk to you a little bit tonight about this live event. I don't know, some of you, if you've been kind of watching my Instagram and my Facebook, you may have seen some announcements about this live event that I'm doing in July. So I kind of want to just kind of explain what it is that I'll be doing and how you'll be able to participate. So with all the shutdowns with COVID, I know there's at least a couple of conferences that I was supposed to present at that were canceled. And I know I am really disappointed about that because I do love going to these conferences and presenting. But I figured life has to continue to go on. You know, you still need to have the benefits that you receive when you go to these conferences. So I decided I'm going to try to bring the conference to you. So July 14th, 15th, and 16th, a little less than a month from now, I will be doing live show, 1 p.m. Eastern time on all 3 days. And I will be covering a different educational topic each day, Cosi Talks 101 style. So we're going to be breaking it down, an important educational topic for you. I am going to have 3 extremely special guests that I am so excited to have physically in the Cosi Talks studio with me. We might have to wear masks at that point. I don't know. We'll figure out when we get to that point. And they're going to be sharing their life stories. And guys, I love sharing the life stories on my show whenever I can, because I feel like everybody has their own beautiful, unique story. But by that same token, when you're listening to all these stories, you can find how it relates to your own life and whatever obstacles you might be going through. So 3 amazing special guests coming on. And then my favorite, something I've never really been able to do on the show, is I will be doing a live exercise demonstration that's going to be related to the topic of that day. So many of you have asked me, what exercises can I do for this? How can I improve my balance here with an exercise? So guys, I'm finally going to have a chance to show you live on the show exercises that are going to help you with my beautiful amputee guests that are going to be on here. So that brings me to my next point. I have a free giveaway tonight. So I know it's not a sponsored talk tonight, but it doesn't mean I can't do a free giveaway. So tonight's giveaway, the Cosi Talks mug. All the cool kids are drinking from it. So if you would like the chance to win one of these tonight, here's what you have to do. Go to my Instagram account at Cosi Talks. So that's my Instagram account, right? And follow me. First person to follow me and tell me what is the day 1 topic going to be will win this coffee mug. Okay, so two things. You got to follow me on Instagram, and you need to tell me what is the day 1 topic for my live event in July. Go. In the meantime, I'm going to screen through some of these comments. Oh, Marlene just said, oh no, this is definitely the right place to put it, Marlene. NBC, the Paralympics are on women's swimming. Oh my goodness. Okay, that's cool, guys. I don't know if you remember Haven Shepherd. She's training for the Paralympic U.S. women's swim team. So I wonder if she's on that tonight. Ooh, I can watch that. Oh, Daniel, that's a great question. He says, what's the average steps per day for a normal active amputee? Well, if you go by the bar that's been set for the average human being, an average adult human being, they recommend taking 10,000 steps a day, which is approximately between 2 to 3 miles, depending on what watch you're wearing, walking around all day. So for my amputee patients, I want them walking just as many steps, if not more, that I am. So depending on the amputee, if they are someone who is independent with their prosthesis, they're not having to use an assistive device like a cane or a walker, I highly encourage walking as a way to stay fit, to keep your mobility going. So Daniel, there is no average steps for the normal active amputee. I would say take as many steps as you can. Carol asks, if you cannot watch the live video, would it be taped? Yes, Carol. I will be broadcasting at 1 p.m. each day, July 14th, 15th, and 16th. Eastern time, and it'll be to my Facebook page as well as my YouTube channel. So if you guys have friends or people who would like to watch the show and they're not on Facebook or Instagram, YouTube is a really easy, user-friendly way to be able to watch the show. Absolutely, Russell. Ashley says, I just restarted PT today because I have patellofemoral pain syndrome. My PT said the knee pain is because of my hips. All the muscles are still pretty weak. How does the weakness in my hips cause my knee pain? So basically, Ashley, the whole saying, backbone's connected to the hip bone's connected to the knee bone, right? All that song, it's all connected. So if there's weakness in the muscles that should be providing you stability, which those are the muscles in your hips, your gluteal muscles, something else has to pick up the slack, and it's going to be your other joints. So if you, oh golly, and I just realized Bob here is still in pieces. I don't have the rest of Bob to be able to demonstrate very well. So your quad muscle, let's start with your quad muscle, Ashley. Your quad muscle starts in your hip, crosses over your hip, and crosses over your knee. And it attaches right underneath your kneecap. So it's a very large muscle that is covering two joints, okay? So with the patellofemoral pain syndrome, a lot of times this muscle and the muscles behind, the hamstrings, are not working well together because there's weakness there. So if you have weakness in your gluteal, you have weakness in the quads and the weakness in the hamstrings, you're going to start to have that knee pain. So the nice thing is when you start to strengthen everything together, that pain disappears. So it's kind of cool. So I know you're going to do just fine, Ashley. And again, it's learning how to target the muscles that you're not using and that you're not activating. And it can be a little bit tricky. You can be a very high level individual and doing a lot of movements. But if you're not activating the right muscle groups, then you're going to run into some of these problems. All right, guys, let's see what's going on here. Daniel says, that might be why I hurt so much. My count is high. Well, yeah, I mean, obviously, guys, do as much walking as you can, as you're capable of doing, and then push yourself a little bit more every day kind of thing. So Ricky says, I do over 10,000 steps just at work. Very good. Okay, so Carrie asks another good question. And guys, reminder, I'm going to check my Instagram account pretty soon. So if you are the first person to follow me and then tell me what is going to be the topic of day 1 of my live event series. Carrie asks, I have another question. If I use a cane when on a long walk, how do you keep it from hurting your wrist? So again, Carrie, when you're using a cane when you're taking a long walk, how much support do you need? If you're using that cane so much that it's hurting your wrist, it might be a good idea to think about maybe using 2 canes just for the long walks. Okay, and I've covered that in the show before, that guys, sometimes you have to have different equipment for your different activities. And especially I find this to be the case with my above the knee amputees who have very short limbs, and also my bilaterals. That, for example, some of my bilateral amputees, they might get around their home independently without having to use a cane or a walker. But when they go out into the community, they might find themselves using a cane just for extra support or to prevent them from getting tired. So Carrie, in your case, if taking a long walk is putting that kind of stress on your wrist, it means that you're putting a lot of pressure into it, which means you're relying upon it a lot. And it could be that because you're just getting tired and you're having to rely upon the cane more. So it might not be a bad idea that when you do these long walks to use 2 canes, and that way you're kind of splitting up the pressure and you're able to get a little bit more out of your walk. But good question. Brent says, I average 9,000 steps, but I don't work or anything. Guys, anything for me, honestly, when I have my patients with their pedometers or their watches that gives them the step count, anytime it's over 5,000, I'm super happy because it means I know my patients are moving around. Holy smokes, Daniel says he did 18,000 steps. Holy smokes, that's a lot. Ashley, you average quite a bit too. Oh, Kristen, thank you for posting that. You are a rock star. Carrie says, I've been using a cane thinking that it will stop the phantom pains. I mean, if it's something that you tried to do and it didn't work, it's not necessarily going to help with the phantom pain. Sometimes using the prosthesis more and putting more weight into the prosthesis. So for example, if you're using, 70% of your weight on your sound limb, 30% on your prosthetic side. If you try to put more weight on the prosthesis and even it out a little bit more, you're kind of feeding your brain just a little bit, and you're giving that brain those signals, and it might help a little bit with that phantom pain, Carrie. So, taking the weight off the prosthesis and not using it as much, I don't think would be the solution there. Again, if you're using the cane for safety, then by all means, continue to use it and continue doing your long walks. So Harsh has got 10,000 steps over the weekend. Y'all are some great walkers here. So David says, I carry a wheelchair, crutches, walker, and 2 canes in my truck everywhere I go. And that's usually what happens, guys. Whenever I have my patients come in, if it's a patient who is not going to be completely independent with their prosthesis, then I definitely work with them to see how independent we can get them, especially in the community, because I want my patients to be participating in society and the community as much as they possibly can and as safely as they can. All right, time to check. Rhonda is my winner here. All right, Rhonda, I will be contacting you over Instagram. Rhonda's the first person to follow me, and Jim, you're right. First topic on day 1 is going to be proprioception. So day 1, July 14th of the live event series is going to be proprioception. What is it and why do we care? This is a talk I've done several times in person to support groups throughout the country. I presented this topic actually at last year's Amputee Coalition conference. Guys, it's a topic that you're not going to hear a lot. Proprioception, a lot of times when I mention it to my patients, they just kind of look at me going, what? Proprio what? It's an incredibly important concept that is very relevant to learning how to use a prosthesis. So I'm going to break it down for you. I'm going to explain to you what it is, why you should care about it, and then more importantly, I'm going to show you exercises that are going to help improve your proprioception, which in turn will help improve your gait pattern. So guys, I do also want to say a big thank you to my sponsors, Blatchford, College Park Industries, and VitalFit. These 3 companies are stepping up to the plate to help me be able to produce this live event for you. And not only are they helping produce this live event, they are providing, I think I counted 11 giveaways. And guys, these are really nice giveaways. We're doing 11 giveaways in those 3 days. Yes, crushing the cockroaches, Carol. We're going to get to that too. People are like, cockroaches, what is she talking about? So guys, if you're interested in learning more about this live event, go to my website. Kristen, if you're still there and you can post that up, that would be so awesome. Here, actually, I haven't posted anything. Let me try posting it with this new software. Let's see if I can get it together. So guys, if you were curious about this live event, when is it? What am I going to be talking about? Lots of giveaways. Go to my website and sign up for my email subscription. I am sending out information about what to do, how you can participate in the live giveaways. For some of these live giveaways, you do have to be signed up for my email account. So quick recap, July 14th through the 16th, live event, 1 p.m. Eastern time. You can either watch it from the Facebook page or you can watch it from the Cosi Talks YouTube channel. Lots of education, lots of information, exercises, bring a friend, tell a friend. All right, guys, I think with that, we are going to go ahead and wrap it up for this evening. As always, guys, thank you so much for letting me be a part of your lives this evening. I will see you guys, same bat time, same bat channel next week. And that's all we got for now.